Right. Welcome to the Level Health Podcast. Today is our first interview with Dr. Christina Rankin, Doctor of Physical Therapy. Do you mind if I call you Chrissy?
Yep, that's totally
It'll
cool.
keep the podcast shorter. So
Yeah.
you are a pelvic floor specialist.
Yes.
Awesome. So that's pretty much going to be the topic of today. That's something that we've talked about in the past. And
Yeah.
just in my own process of trying to find my weak points, I realized that was a huge
Mhm.
weak point for my understanding of, everything about it. But before we go into that, the nitty gritty, the signs of dysfunction, stuff like that, can you give me just a little bit of background of what got you into PT in the first place, just generally, and then also this much more complex section, the pelvic floor?
Yeah. Sure. So I always knew I wanted to be in healthcare ever since I was a kid, and I didn't know what type of healthcare. So I did a lot of shadowing, volunteering in different facilities and different aspects of healthcare. And I thought I was going to go into athletic training, and then I realized that wasn't exactly what I wanted to do. So then physical therapy was the perfect step over from athletic training, and so that's how I got into it.
Okay.
Yeah,
The athletic training what is the difference there, just real quick, between athletic training and physical
sure.
therapy?
Yeah, so athletic trainers and physical therapists do have an overlap. They do both corrective exercise and rehab in some instances. However, athletic trainers tend to be more on the sidelines, on the field. They work a lot with acute injuries and then manage them alongside a physical therapist. There is a little bit of education difference as well. You could technically be a athletic trainer after a bachelor's degree, and then most people go to get their master's in as a GA, which a grad assistant, and that's kind of how it goes. Whereas PT now is a doctorate profession, so there's a little bit of educational differences, but we are very very similar in that aspect.
And getting into the physical therapy, what brought you to specifically pelvic floor? Do you still do just the general physical therapy, or are you really hyper specialized now?
Um, I do generalized ortho as well with pelvic floor. Most people do both. In the pelvic floor world, there are a few instances where there are people who just do only pelvic floor. However, it is pretty draining, both mentally and physically. And so sometimes you need the offset of, I want to treat a knee today because sometimes that's sometimes a little bit just easier mentally and physically. So most people do both. But I remember I was in third year of PT school, and I wasn't quite sure where I was going to land in regards to like a specialty. Technically, in physical therapy, you don't have to specialize, but most people tend to go towards one direction, just like physicians. And we were sitting in class, and my undergrad degree is in human development and family science. And so I felt that I was missing that human connection and that human um, in human development aspect of it. And we were sitting in class, and a public floor physical therapist came and talked to us, and I knew right away that that's what I wanted to do. And so I made the steps in order to make sure that I could get a job in that field, and a mentor that could help me. And then it kind of went from there.
So, in your time that you've been a physical therapist, how have you seen the field of physical therapy evolve generally, and then also again that specialty? Because in my limited experience and research in this field, it seemed like there's still a lot of confusion and misunderstanding, even amongst
Mhm.
practitioners.
Yeah. Yeah, absolutely. I think in terms of the progress or the changes that uh, general physical therapy has gone into is that people are interested more in weightlifting, I guess, or higher level rehab. Whereas before, we would give like a lawn art quad, which is just like a leg extension, but with 5 pound weight cups, right? And then we say, okay, now it's time for you to go to a personal trainer or the gym and do them yourself. And so I think uh, us practitioners are learning that we're underdosing and we're under prescribing exercise for people. So I think that is a good positive change that we're seeing. Um, However, I do one thing that I do find that is a little unnerving sometimes is those that people were kind of fighting against each other a little bit too. So there's other people who are like other camps who are really strong in manual skills and say like everyone needs manual skills and everyone needs like these specific manual skills, and then they don't do heavy exercise, and then the heavy exercise people are like, well, manual therapy is BS and it's like not, and it's pointless and there's no evidence. And so unfortunately there right now, because we live in such a social media like hyper vigilant world, that there tends to be a lot of like fighting into who like for validation and like who they think is better and who's wrong and who's right. So I do find a little bit of that too. So even though we're progressing, I think we're progressing in terms of our knowing that our profession is at a high level academically, but we're still fighting with each other, which is not which is not good.
Yeah, yeah, you see that in across the entire health and fitness industries, getting married to ideologies and specific modalities, and you see some success with that. And I think that it's just kind of human nature. We think what works for us will work for everybody, or what has worked in the past will continue working. And I think that breaking apart from that and looking at whether you're a professional or just a person in health and fitness, looking at it objectively can do you just a world of good. So
Yeah, absolutely.
diving into kind of the main topic, can you explain to me? I found a few different definitions, but on your end, what is pelvic floor dysfunction? What does it look like to be a pelvic floor physical therapist?
Mhm. Yeah, sure. So I did do a little bit of research, so I can like really make sure I'm using the right terminology. And so in in physical therapy, there are sections that are now called academies. So the Academy of Pelvic Health Physical Therapy is the essentially the gold standard of pelvic floor physical therapy, and they define um, evidence-based physical therapy services regarding the pelvic floor is everyone from childbearing women to perimenopausal mothers to young athletes to men to trans people with incontinence, pelvic pain, constipation issues, prolapse symptoms, also abdominal pain, and things like that. So um, we we essentially treat the pelvic floor, which is a group of muscles at the bottom of our pelvis. But we don't just use those muscles. That's a starting point. Um, since the pelvis and the pelvic floor are right in the middle of our body, it then literally connects us from head to toe. So we look at the whole person and we're seeing not only how is the pelvic floor functioning, but how is the rest of your body functioning that is contributing to dysfunction, which looks like incontinence, pelvic pain, pain with sex, prolapse, diastasis recti, erectile dysfunction, heavy menstrual periods, infertility in some cases, and stuff like that.
So it has significant repercussions across the board. Now, is that when there is pelvic floor dysfunction and you're seeing those side effect symptoms, and how it would be phrased,
Yeah.
do you look at something structural? Do you look at something neurological? What is that assessment process? What does that look like? Is it
Yeah.
exclusionary? Or are you just ruling things out until you find what it is?
Yeah, so with any form of diagnostic criteria, we are looking at every system. So we are looking at cardiovascular, we're looking at nervous system, we're looking at musculoskeletal, we're looking at endocrine, we're looking at all of the systems and making a diagnosis off of that. Now, technically in physical therapy, we can only give a musculoskeletal based diagnosis. So meaning pelvic pain or stiffness or weakness or something like that. But that's all an umbrella term that we can also diagnose underneath that. And so a typical evaluation that I do is that I take an extensive history. And I'm not just saying the past 6 months, I'm talking years and years and even childhood, depending on the situation. So we take extensive history, we talk about all of those systems, endocrine, which is your hormones, cardiovascular, respiratory, GI, bladder, reproductive, all of that. And then we then do a physical exam. And we generally start with a physical exam that looks like posture and strength and range of motion. Look at your movement patterns. Look at your skin quality. Looking at is there swelling in the body and that kind of a thing. And then eventually we look at the pelvic floor specifically, and we can do that a couple ways. One, we can use biofeedback, which is either using electrodes that measure electrical activity of the muscles. We can also use an ultrasound machine that we can either put on the perineum, which is the area between either penis, vagina, and the rectum, or we can put it on the abdomen, or we can do also an internal exam. And most people don't realize that we can do an internal exam, and that gives us a lot of information. But we also give the patient a choice. We're not, so, we've always been taught that the patient is the number one decision-making person, and we give them all the information and then they make the best decision for them.
Yeah, so I'm guilty of this myself. I honestly, I mean, the physical therapy field obviously covers all the systems. It has to, or it should, provided you're taking the body into account as a whole. I was under the impression that it was entirely musculoskeletal. In fact, I think you pointed that out on your questionnaire, and then someone else did later on. I'm like, okay, I got to rephrase this entire thing. Then with the pelvic floor specifically, I did not know that it was that in depth. And that there was, I mean, even that digital exam, the EMG makes sense because it could be hyper or hypotonic.
Yep.
Is there any like big order things that, because I would imagine a lot of people that are coming to you are going to have multiple things wrong. Is there a hierarchy that you try to establish? Is it movement patterns first, muscle recruitment first?
Yeah, that's a great question. I meet the person where they're at, or try my best to meet the person where they're at. And we've had that discussion before, where in all aspects of patient or client interactions, we're trying to meet where they're at. And so if I had a choice, I would love to start with actually body awareness and movement awareness, and knowing the difference between what something feels good in our body and what doesn't feel good in our body, or understanding what our body is capable of doing and what it should feel like, and that kind of a thing. So I actually like to start with body awareness, which usually goes into diaphragmatic breathing. And that's usually like kind of where I start. And then I go from there. It also depends on the complaints. So if this person is having more of a pain response, then I'm going to start with calming down the nervous system, which is breathing, which is stretching, not for mobility, but stretching in aspects of I'm calming my nervous system from fight or flight to rest and digest. I'm teaching them education is a huge proponent of pelvic floor physical therapy. We don't do a great job in, let's say, early education about what our body does, and understanding what's normal and what is normal bowel movements, what's normal bladder habits, what's normal menstruation, what's normal sexual function. So just starting there is where we tend to start too. So I always start with body awareness and education first. And then it kind of goes down to symptom, what the patient finds is the most important thing. If they want to bench press 200 pounds but yet they leak every time they do that, okay, so like I'm gonna look at ways that I can help you with a bench press, which doesn't happen very often. I don't know why I picked bench press, but that was what it was in my brain.
That's a good bench press.
Yeah. We starting there. So how can I combine that bench press with a musculoskeletal position and with a pelvic floor position, and then we kind of go from there. So I would say if I had to choose, it would be body awareness, education, and then the musculoskeletal / nervous system, both autonomic and also the regular nervous, the central or peripheral nervous system, either one.
I think that breath work is something that a lot of people can, not even within this specific population, but in general benefit from. Could you say that that's kind of like an anchor for you? Because if you are not, especially with the pelvic floor, I'd imagine that the pelvic floor
Mhm.
muscles are going to be contracted if you're in that sympathetic state. And if you're always in this low level of sympathetic arousal, then those are always going to be a little bit toned. And
Yes.
is that kind of safe to say that if you're not taking care of that right out the gate, or at least identify whether it's probably an issue, like knowing Americans is probably an issue, do you
Correct.
take care of that just right out the gate because you won't be able to make much progress outside of that?
Correct. Yes,
Mm.
absolutely. And so, and not only in a hyperactive state, we can also use it to understand, let's talk like prolapse for a little bit, that a lot of times people have difficulties with prolapse because they have pressure in their abdomen that they're not controlling as well as they could or as efficiently. And so the breath is also part of that too. When we take a breath in, we're putting pressure, increased pressure in our abdomen and our pelvic floor, and we're also kind of lengthening our pelvic floor while we're breathing in. And if we're lifting something while we're holding our breath and essentially pushing down, then that kind of creates or exacerbates those symptoms. And there's other things at play too, but that's a very simple way to describe it. So understanding that when we exhale and not just completely holding our breath and clenching, we're allowing the pelvic floor and the organs to be in a more strong or a better optimal position. So we're kind of using the breath in multiple aspects and knowing that breath affects our body emotionally, but also physically. It's not just like we need to breathe in order to be alive. We also can use the breath to not only affect our muscles, but also our nervous system. So it's a
So
little bit of both.
So yeah, I was going to say, so the breath is really touching all of the things, the nervous system, physically, making sure that that breathing pattern is appropriate in just an effective way, for lack of a better term. You mentioned the
Yeah.
load bearing exercises causing issues. What are some other
Yeah.
common contributing factors? I'd imagine things like sitting and obviously the lifting, straining while pooping, things like that.
Yeah. So, in regards to prolapse in general, we can also put in lump incontinence with it too under load. We can. What increases risk of having those symptoms is women after vaginal childbirth. Um, doesn't mean that you guarantee to have it, it just increases the risk. A higher BMI does, and not necessarily meaning that if you're overweight, you need to lose weight. It's more of there is more pressure on the pelvic floor because there's just a higher BMI. Also, if there was a significant injury during childbirth, so sometimes you can have an avulsion tear, which means the actual muscles separate from the bone. That's a pretty rare situation, but that can happen. Also, to weakness in general, decreased hip range of motion, that can also increase symptoms as well.
Before I actually hadn't even thought about this question until just now, but can you
Sure.
explain to me the this is going to sound funny, but the biomechanical benefit of putting your feet on a squatty potty while you're pooping?
Oh, sure, absolutely. So, in the majority of the world, we squat to go to the bathroom. So there's like a hole in the wall, or a hole in the wall, hole in the floor,
Yeah,
and
I've
then you
been
put your
to
feet.
Hong Kong in the
Oh,
mall,
yes.
all over the world. It's pretty much everywhere except for here.
Yeah, pretty much. And so we squat in order to, you have to squat in in that type of environment. And so in Western toilets, we are not able to squat over that. And now that since people aren't squatting in their everyday life, toilets seem to be getting higher and taller. So then when we aren't in that squatting position, our rectal our puborectalis muscle, which is the muscle that surrounds like a sling around the rectum, it is then shortened or clenched together when it's not in a squatting position. So we're at an angle where it's not opening completely, it's not letting go completely, and then it has a hard time of straining, getting stool out, emptying completely, that kind of a thing. So when we use a squatty potty, it just helps us kind of put ourselves in a squatting position to counterbalance or counteract what the Western toilets do for us. So you want to make sure that the knees are higher than the hips, so that you do have that angle where that pubal rectalis muscle is actually at the the longest that it can be, or the less taut that it can be.
So correct me if I'm wrong, but it seems like that kind of, so we should not be pooping on a normal toilet. The like
Yeah.
just from a muscular perspective, it's a bad idea. Is there any longitudinal evidence on that before? Because this is obviously pelvic floor related. Is there any
Yeah.
longitudinal evidence of like occurrence of issues later on in life?
Yeah, so if you have chronic constipation, there tends to be an increase risk of pelvic floor dysfunction. You can also, and not only just pelvic floor dysfunction, but not being able to empty completely means that there's still stool in our body that needs to be out, and that toxin is then building up in our system. And so, how does our body try to get rid of that toxin? Like, we get sick, we start swelling, our immune system, is kicked in, our other organs might be affected as well. So if we even just think musculoskeletally, when we strain constantly and trying to get hard stool out and we're not in an optimal position, we can have pelvic floor dysfunction. But then also, just physiologically and pathologically inside, we can have higher toxicity levels and other things that can come to play at that as well.
Okay, yeah. It's funny because when me and my girlfriend were moving in together, I was literally the same day was thinking, how am I going to tell her that I have to have a squatty potty? And then
Mm.
she messaged me and asked me the same thing, so I was let
Oh,
off the hook. But yeah,
nice.
it just seems like just an obvious thing to consider, and I mean something that you should be doing every single day. And if you're doing it in a way that's
Yes.
degrading down there, so
Yeah.
one more. Okay, actually, I'm glad we got to take that sidetrack
Yeah.
because that's something that I don't think anybody really is aware of. I think it's like, oh, you got a squatty potty. I don't even know. Like they think it's just like a novelty thing.
Oh,
Um,
yeah.
so the big differences between male and female, in terms of coming to see you, I think maybe, or just pelvic floor specialists in general. Common causes. What are the more common signs? You mentioned a little bit of from both genders, but
Yeah. So that is partly so the Academy of Pelvic Floor Physical Therapy was created in 1977, and it was originally the section of obstetrics and gynecology, which then only limits like essentially like pregnancy related things. And then it changed to the section of women's health, and because unfortunately pelvic floor dysfunction affects women at a higher rate. However, we also know that children can have pelvic floor dysfunction, males can have pelvic floor dysfunction, trans people have pelvic floor dysfunction. And so just calling it women's health, unfortunately, does not cover the whole basis. So in regards to men, there tends to be a higher risk of pelvic floor dysfunction when you have a pelvic type of either cancer or surgery. So whether it be like a prostate removal or prostate cancer, tends to be the higher um, a higher percentage of people come to us with that, because they can have leakage and swelling after prostate removal or a TURP, which is a procedure to help decongest the prostate. There's also men that also have pelvic pain as well. It's not as well talked about because unfortunately, not only are it's such a taboo to talk about the pelvic region in general, but then for some men to admit that they have pelvic pain is really difficult. So men can also have pelvic pain. It's not as common, but it does happen. Also, men may have erectile dysfunction as well. And there are other ways, there are physical ways that it can be causing as well. So those would be the main things that men would come to us for, but it doesn't happen as often. And whether it be because of embarrassment or urologists, which are what men tend to go see when they have those problems. They just aren't referring people to that. That could also be happening as well.
Yeah, I imagine that outside of the specific pelvic floor physical therapist, I imagine there a lot falls through the cracks, which is not understanding that. You mentioned pelvic floor pain, and I did read that oftentimes pelvic floor issues can defer elsewhere, transfer
Yes,
that pain elsewhere. But can you talk
correct.
about that real quick? And then also just how
Yeah.
else does it transfer? Does dysfunction in the pelvic floor then transfer up to the ribs, knees, hips, everywhere?
Yeah. So the most common referral patterns for pelvic pain is the inner thighs, the hips, the low back, and the abdomen. So a lot of times when it comes to hip and low back pain, say someone has been to a traditional physical therapist or just an a trained therapist, and nothing that they do gets better. That means that's a sign usually that the pelvic floor could be involved. So understanding that pain can refer to other places is important, and that's more of a direct connection. Now, other times what we see in a more anecdotal way is that people that have pelvic floor pain also have TMJ or neck pain, both in a just a physiological way, meaning if I'm clenching my pelvic floor because I'm in pain or because I'm trying to protect myself, I'm most likely also clenching my jaw and my neck. Um, there's also other ways too where when we develop in utero, so when we're in a uterus as we're developing, the neuro connections between the TMJ and the pelvic floor, the coccyx area, or the tailbone area, um, uh, are connected by the same dura mater, which is a part of the nervous system or the spinal cord. So there's also an anatomical connection as well. So it's a little bit of both. It's both like a physiological compensatory situation, and also there's a anatomical connection as well.
That's fascinating.
Yeah.
I'm sure that there's all types of those connections from all over the
Mhm.
body. And is it
Yes,
so, man,
absolutely.
that's very interesting. Okay, so now to bring it back to a little bit more practical, although
Sure.
that was fascinating. Um, the how is the pelvic floor involved with moving into kind of just active people, resistance trained individuals? How does that transfer over to the movement, just general movement? How can it affect general movement, stability, trunk stability all the way through the hips? And then just force transfer, is it going to disrupt
Mm.
movement patterns? Is it disrupting movement patterns? I know it's tied intimately with the diaphragm, which is then tied
Yeah.
intimately with your spine. So
Yeah, I think that's a great question, and there's multiple steps there. So, the first one that I would say is that in regards to stability and like core stability, we like to think of the core as from the pelvic floor, I essentially all the way to the neck. But if we want to just talk about the diaphragm to the pelvic floor, we can do that too. And so they work as a system. So the diaphragm and the pelvic floor, and then your transverse abdominis and your multifidi. So those are other muscles in the trunk area, all work together to make a cylinder or like a canister. And a lot of times in the weightlifting world, they talk about the Coke can kind of a scenario. And when they all work together, they all create this pressure system that moves in and out and up and down together. And that comes from the breath. And we can also stabilize and make that canister rigid by again using the breath or using like a weight belt or something like that. So what we hope is that when you're under load, that your Coke can is not collapsing, that everything is 103, 360 degrees all the way around, nice and stable. When either any of those systems are not working as well, then we lose that rigidity in that Coke can, and then we might not be able to lift as heavy. We might have pain somewhere in the back or the hips or the knee. Um, we can have leakage, we can have prolapse symptoms, we can have hernia. Anything like that can be contributed to that long term. Um, Not saying that heavy lifting causes those things. It's just it's a risk factor, or it can be a cause of that. So that would be how the pelvic floor and the core, or in the core stability, goes into there. Now, regarding force transfer, so since it is in the middle of our body, it is transferring force between the lower body, or our legs, and our upper body. So think about when we talk a lot about how hips and shoulders go together, and especially opposite hips and shoulders go together, because if we think about walking, as one hip is forward or one leg is forward, the arm swing on the other side is supposed to be backwards. And so if we think about how they're connected that way, then we know that we can, what's in the middle, and the middle of that is our pelvis, or our pelvic floor. And so there is a force transfer there as well. And even if you think about anatomically, there is a ligament called the sacrotuberous ligament, which is a really thick ligament that connects the fascia between, let's say, like the hamstrings and the glutes to the lats on the other side. In a more general way, they've had to do like specific dissections of anatomy of cadavers to see that connection. But there is a force transfer there with the fascia connection and that sacral tuberous ligament. And then you had mentioned the lumbar spine and the hips. So let's say that the hips are lacking external or internal rotation, whether it be in a weakness standpoint. So if, let's say that we're missing strength and external rotation in the hips, then that also can be a sign that there might be some pelvic floor weakness as well. And then if you're lacking internal rotation, or it tends to be really stiff in internal rotation, that can mean that the pelvic floor is hyperactive, because some of the internal rotators of the hip are connected into the pelvic floor. And so that's where that connection is. And then if the spine isn't moving as well, like if we're not having both lumbar flexion and extension, but also thoracic rotation, if we're missing any of those, then that can change the forces on the pelvic floor as well. So it's
So
definitely all connected.
So that seems to be kind of a big part of your process, is hitting those points. Actually, put your diagnostic process and your assessment is actually putting those joints into those positions and seeing where there are limitations or weaknesses, or and that makes
Correct.
complete sense. It's tied into the spine. Everything's tied in together. You
Yes.
talked about fascia. Fascia. We'll have to probably do a talk sometime about fascia, because
Yeah.
it's one of those other things that I don't even know if personal training certification even
Mm-hmm.
mentions fascia.
Mm-hmm.
And obviously it probably is a little bit outside of that scope, but it's such a big part of movement mechanics, and movement in general, and pain, and just general dysfunction. And then
Yeah.
it's interesting that the body is so good at compensating. You mentioned having that
Mm.
cocan, and you imagine you have an energy leak somewhere, maybe it's hyperextension of the spine, something, and you are not able to transfer force, but your body finds a way. And I think that's a huge misunderstanding, understanding the importance of positioning, specific joint positioning, but also
Mm-hmm.
entire body positioning during gross motor movements is something that I think
Mm-hmm.
is very, very, it's lacking. It's not taught as a science in personal training. It's taught as more
Mm-hmm.
of an art. It's not even really talked about. It's just like, it's kind of just like, does this look wrong? And obviously you get
Mm-hmm.
some biomechanics within the certification, but there's not anyone there telling you like, hey, this is why this is wrong. It's
Mm-hmm.
just, this is a wrong movement. And they give you some like overactive, underactive muscles, but obviously it goes much more deep than that.
Yeah, and I would say, at least in my background, of my physical therapy education, I would say we were also lacking in some of that higher level, like looking at movement patterns and determining what was wrong, because we did it more of a joint by joint teaching, which most medical schools and any type of higher level education tends to do, because for testing purposes, that makes it really easy. However, when I took like the CrossFit level 1 certification, it was compounded movements and looking at all of it together. So unfortunately, even in physical therapy school, like there wasn't much of that either. And I will say though, it's kind of, I don't know. I always feel in the health and wellness world, they're like pendulum, and it's always either side and it's never in the middle. And so There used to be like a really big pull of like squatting and deadlifting and overhead press and like all of that stuff needs to look exactly the same on every single person, so that you can have the proper form and the proper force transfer and all of that stuff. However, there are some people, like you said, you alluded to earlier, that have body composition compensations that they'll never change. And so it's going to change how that squat, deadlift, overhead press looks. And so knowing that yes, we want this general direction or this general movement to look this certain way, but know that there is variation between that, that what works best for the client or the patient. And that's kind of where that fighting happens too in like physical therapy world, and where like, no, it has to be perfect, but then yet no one is built perfectly. Like everyone's different. We're not symmetrical all the time. So
I think that's already bled into the fitness industry just with
good.
the social media. Like, I mean, you'll
Yeah.
see like the shape of somebody's hips, and it's like there's no way that this person's going to squat the same. I mean, that's something that I think it's probably difficult to talk about because it's not cut and dry. You can't look at somebody that has these dysfunctions and really know what they're going to look like when they end up being squatting correctly. You can't
Yeah.
impose some model on them without understanding anything about the parts of them that are going to go into that model. And that kind of feeds
Exactly.
in perfectly to like really the keynote question. How can your industry improve? You've touched on it quite a bit already,
Mm.
I think.
Mhm.
But what are your other thoughts on that?
Yeah, I think that we could do a better job with language. And I'm having my own growth in this as well. But in all medicine, including physical therapy, we do a really good job of blaming patients. That the patient is the reason why they have all of these problems and the traumas that they had in their life. And like, you just, it is what it is. And it's like your fault. And if you don't get better, it's also your fault too. Well, can I cuss?
Oh, yes, of course.
Okay. I
Sorry,
was
I
like,
was
that's really,
focused.
no, you're like, that's really shitty. Like, no, that's not how we should be looking at it. So using language and being informed of proper motivational like interviewing essentially, and trying to really help the patient and our clients know that they are in charge and that we are they I'm the GPS and I'm giving you 5 different ways to go, and then you were driving the car, right?
You're the
Kind of a
guide.
thing.
You're
Yeah,
playing the role of the
exactly.
guide. I'm actually halfway through motivational interviewing for
Hey.
in healthcare,
Oh,
recommended
perfect. Yeah.
by Dr. Fundero and the comprehensive
Oh,
coaching.
yeah.
I just finished with some acceptance and commitment therapy. So this has been kind of that was an awesome question. Thank you, by the way. I'm
Yeah. Yeah.
I think that problem persists into personal training very, very, very much so. And I think personal training is looked at like a little bit more of an entry level position, and that's understandable because a lot of it is an entry level position. But understanding this psychological side of thing, understanding how to
Mm.
speak to people, how like you can find somebody at all points in their journey, and you need to be able to identify not only what would be appropriate at that point in their journey, but what would be appropriate for that person at that point in their journey. And that's something
Yeah.
that I told Haley the other day, being a personal trainer is a lot like just shooting in the dark and adjusting. But now you add that psychological component, and now you're shooting in the dark with your eyes closed, but you can still adjust. It's just about getting better over time, finding small
Yeah.
little things that they can do to improve. Um, all right,
Yeah,
thank
there's
you
a
very
couple of
much.
things there.
That was
Just
awesome.
one thing. Yeah, I
Yeah,
was gonna say one more thing. I another a system that you just hit on is like a lot of mental health goes into especially pelvic floor stuff because there is so much shame around their symptoms, and so addressing the mental health is also important too, just like it is for literally anybody. And so we make sure that we refer people to those people as well. So
yeah. Human beings are not robots.